بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. Today we are going to talk about typhoid fever, which is frequently asked in our MRCP exam. But before we dig deeper into the topic, we need someone to read a common exam scenario for us. So, can you read it for us, Dr. Nada?
Yes, of course. A 25-year-old man is admitted to the internal medicine department complaining of high fever that had lasted for 12 days. He has recently returned from traveling in India. On his last day in New Delhi, he had an acute episode of watery diarrhea that lasted 24 hours and subsided without treatment. 2 weeks after his return, he started to feel feverish with headaches and anorexia. His temperature rose to 39.4 degrees. He visited the emergency room where his examination and CBC were normal. He was discharged home with a diagnosis of viral infection. After 4 days with no improvement and the appearance of dry cough, he was sent again to the hospital and was admitted. Before departing to his trip, he received hepatitis A, hepatitis B, and typhoid vaccine, VI vaccine.
Thank you, Dr. Nada. As you can see, typhoid fever it usually comes in our exam as fever in a returning traveler. We have two big topics under the same title, which are, of course, number one is malaria and number two is typhoid fever. So these topics are high yield. So let's dig deeper into typhoid fever. Typhoid fever is caused by a certain type of bacteria called Salmonella typhi, or the full name Salmonella enterica serotype typhi. This bacteria is a gram-negative root or bacilli, which is facultative anaerobe with flagella, and it produces hydrogen sulfide. It's oxidase negative and cannot ferment lactose. What's important is highlighted in yellow. So the fact that Salmonella has flagella is important, and you can remember this fact by the mnemonic Salmonella has flagella. It's like a musical word. So if we come to the virulence factor of the bacteria, the cell wall of the typhoid pathogens contains endotoxin, which are responsible for neurologic symptoms associated with typhoid fever, such as delirium and coma. So this is important because you may be asked or you may be given a scenario of a case with typhoid fever complicated with delirium, for example, and he may ask you why this occurred. This is because the fact that Salmonella typhi, it can secrete endotoxins. So let's come to the pathophysiology. The first is life cycle. The story begins with oral uptake of pathogens, and there is an interesting fact here which can be asked in the exam, that a relatively large number of organisms is needed to cause the infection. This is referred to as high infective dose. This is because the bacteria, they are sensitive to stomach acid or HCl. So a large dose of the bacteria is needed to cause the disease, and this is unlike Shigella, which is commonly compared with typhoid fever, where as few as 10 organisms only can cause the disease. Number two is migration to Peyer's patches of the distal ileum. The bacteria migrate via M cells through the epithelium and into the Peyer patches. Let's see what's meant by this by viewing the next slide. As you can see, if the bacteria manages to reach the distal ileum, it will be presented to the Peyer's patches through a special type of cells called M cells. M cells, they are antigen presenting cells. They will present the Salmonella typhi to Peyer's patches, and Peyer's patches, they are sometimes referred to as tonsils of the small intestine. So they are responsible for catching or draining any foreign antigen. and you may also be asked about the exact location of the virus patches, which is in the submucosa of the small intestine. So let's read the remaining pathophysiology. So infection of macrophages, if the bacteria infects the macrophages, it can spread to the bloodstream and it can cause septicemia and systemic disease, and also the bacteria can migrate back to the intestine to be excreted in the feces. So if we come to more details about Salmonella, the first is the reservoir. Salmonella typhi, humans are the only reservoir for it. So don't expect to catch the disease from animals, for example. And this is important because if compared to other types of Salmonella species, where infection can occur from animals and humans, Salmonella typhi only affects human. So if we come to the mode of transmission, the mode of transmission is fecal oral, and this can be achieved via two routes. The first is direct person-to-person contact, and what's important here is that asymptomatic carriers can still infect normal people through the fecal oral route. So the pathogen may be transferred from contaminated stool via handshake, for example, to the next person. So the other point is indirect, in which contaminated food and water, such as drinking water and sewage system, are not properly separated, or a carrier prepares food. This is important because this highlights the significance or the importance of hygiene in preventing typhoid fever. So if we come to the next slide, the clinical features of the disease. Generally, incubation period is 6 to 30 days, or most commonly from 7 to 14 days. If left untreated, the disease passes through 3 different stages, and each stage lasts about 1 week. And after 3 weeks, there are two possibilities: either slow regression of symptoms, or patients become chronic Salmonella carriers. So progression of illness in week 1, for example, patients usually present with gradual fever in a stepwise pattern, and this means that the fever is maximum at night and lowest at morning, and this is sometimes referred to as nocturnal fever. And number 2, there is relative bradycardia, and this is because when temperature rises by just 1 degree, the heart rate will rises by 10 beats per minute. This is the physiologic response which occurs in any normal person, but this response is blunted in patients with typhoid fever. This is referred to as relative bradycardia, or sometimes it's referred to pulse temperature dissociation, or sometimes it's referred also to a sign called Fagot's sign, and this can be asked in your exam. So let's read what's meant by Fagot's sign or pulse temperature dissociation. It means the presence of both fever and bradycardia, and this can be caused by many infectious diseases, including yellow fever, typhoid fever, dengue fever, Ebola virus disease, brucellosis, tularemia, Legionella infection. What's important here are typhoid fever and Legionella infection. And you should note that malaria, which also an important cause of fever in a returning traveler, does not cause pulse temperature dissociation. So let's come to the third point. It's constipation or diarrhea, and this point will explain more in the next slides. And also patients can complain of headache. So let's come to the next slide. In week 2, patients will complain of persistent fever, but there will be no chills, and this fever is unresponsive to antibiotics. And very important point is that patients will develop rose colored spots. This is only in 1/3 of affected individuals. So these are small speckled rose colored exanthem that appear on the lower chest and abdomen, and most commonly around the navel or umbilicus. So let's have a look at this type of rash. See, it's rose colored or red in color. And I have a question here that you can send me the answer. Do you know any other diseases which are also associated with rose colored rash? I need at least 3 diseases. If you know the answer, you can comment on this lecture, or you can send it to our Facebook group. So the third point is typhoid tongue. It's a grayish, yellowish, coated tongue with red edges, and patients usually also complain of non-specific abdominal pain and headache. And this is a important point, which is diarrhea. Diarrhea is usually comparable to pea soup, and it's caused by purulent bloody necrosis of the Peyer's patches. And patients can also complain of constipation up to the degree of bowel obstruction or intestinal obstruction as a result of swollen Peyer's patches in the ileum. So patients can complain of constipation or diarrhea, not only diarrhea. So the last point is neurologic symptoms such as delirium and coma, and this is caused by the endotoxin secreted by the bacteria. So let's come to the last week or week 3. Patients, other than symptoms in week 2, patients can also develop possible complications such as GI ulceration with bleeding and perforation, and this occurs due to necrosis of Peyer's patches. And patients can also complain of hepatosplenomegaly, or they can have hepatosplenomegaly, and in rare cases patients can have sepsis, meningitis, myocarditis, or even renal failure. And what's important here is that typhoid fever, it's a systemic disease. It's not limited to the gastrointestinal system. So always think of typhoid fever as a systemic disease. It's not only a gastrointestinal disease. So let's come to diagnosis of typhoid fever. We need to read this paragraph first. So we should suspect typhoid fever in patients with fever and GI symptoms such as diarrhea who have traveled to endemic area, and diagnosis is confirmed with detection of Salmonella typhi in cultures. So the most important step to diagnose typhoid fever or a confirmatory study for diagnosis of typhoid fever is blood cultures. So blood cultures should be indicated in all patients, and it's the most important diagnostic tool or the gold standard test for typhoid fever. And blood cultures can be positive starting from week 1 of the disease. And interestingly, we can do other cultures as well, such as stool culture, urine culture, or even bone marrow cultures. In stool cultures, it can increase the chance of pathogen detection or to identify chronic Salmonella carrier. But stool cultures are not preferred like blood cultures because they have low sensitivity, and they may be positive starting from week 2. And more importantly, stool cultures cannot distinguish between current infection or recent or acute infection and chronic Salmonella carrier, because it will be positive in both cases. And urine cultures, low sensitivity. Bone marrow cultures, more sensitive modality, but it's rarely performed because it's invasive test. And we can do also some routine lab studies, but of course we cannot diagnose typhoid fever with routine lab studies. Can you read for us, Dr. Nada, routine lab studies for typhoid fever?
Okay. Not typically indicated, but if performed may show some of the following findings, such as TBC with differential, such as anemia, leukopenia, or leukocytosis, eosinophilia, relative lymphocytosis, thrombocytopenia.
Actually, it's eosinopenia, Dr. Nada, means decreased eosinophil count, not increased. I just need to add something important here, is that typhoid fever is normally associated with leukopenia. But if you find leukocytosis, we should think of complications such as intestinal perforation. You can see in this box there have been some reported cases of adults with leukocytosis. You see, leukocytosis, which could indicate complications such as intestinal perforation. So, can you complete, please, Dr. Nada?
Yes. Inflammatory markers increase CRP, liver chemistries increase AST and or ALT, BMP may show abnormalities in patients with severe diarrhea, such as increased BUN and increased creatinine, and electrolyte disturbances.
Thank you, Dr. Nada. So, there is also an important point which is commonly asked in the exam, which is regarding Vidal test. Vidal test is a form of serology or antibody against Salmonella typhi, but its use is not recommended. You know why? Because it has low sensitivity and specificity and inability to distinguish between current infection and previous infection. And there is an important point that typhoid and paratyphoid fever are nationally notifiable disease, and also malaria, by the way. This point can be asked especially in BASIS exam. So if you come to treatment of typhoid fever, we have general principles such as consulting an infectious disease department or infectious disease specialist for guidance, and we should start antibiotic treatment based on antibiotic susceptibility, and we should keep in mind that resistance is widespread, resistance to antibiotics, and also in patients with severe infections such as delirium or coma or shock, we should provide supportive care such as fluid resuscitation. Also, we should manage complications such as GI perforation or GI bleeding. And this point is important. We can administer corticosteroids such as dexamethasone. So in severe cases, we can give, beside of course antibiotics, we can give dexamethasone as an anti-inflammatory medication. And we should monitor response to therapy. Fever is a very important guide for us. Fever resolution in 3 to 5 days, or there is relapse and also complications. We should monitor patients for complications such as chronic Salmonella carrier. If we come to the next slide, which is the choice of antibiotic, we should start empiric antibiotic treatment based on the disease severity and the risk of resistant pathogens such as traveling to South Asia or Iraq. And the antibiotics which are preferred in cases with typhoid fever are either ceftriaxone, which is a third generation cephalosporin, or azithromycin, which is a macrolide. And this fact is important, by the way. Quinolones such as ciprofloxacin, they are no longer preferred in typhoid fever because of high resistance rate. And in severe infection, we can give third generation cephalosporin, it's preferred, and we should tailor for further antibiotic treatment based on antimicrobial susceptibility testing or based on blood culture and sensitivity result. And there is an interesting fact here that antibiotic prolong the duration of fecal excretion of Salmonella typhi, and this is important because of two things. If fecal excretion of Salmonella typhi is prolonged, we should expect that these patients can infect other easily. They can spread the infection to other people, and also we should be able to differentiate this to with chronic Salmonella carrier. We'll know what's meant by this in the next slide. So the antibiotic of choice in typhoid fever is either ceftriaxone or azithromycin. So let's come to the next slide, which is about complications. We have either acute complications or chronic Salmonella carrier. For acute complication, can you read it for us, Dr. Nada?
Yes, of course. Acute complications such as GI and hepatobiliary, such as bowel perforation, GI hemorrhage, cholecystitis, hepatitis. Cardiac complications such as myocarditis, respiratory complications as pneumonia and bronchitis, And finally, neurologic complications such as altered mental status, as encephalopathy and delirium, and meningitis.
Okay, thank you. As you can see in this photo, there is ileal perforation, and the problem is this can result in secondary infection of the peritoneum or secondary peritonitis. All these are acute complications of typhoid fever. As you can see, it can affect many systems in the body. So if we come to another high yield point in typhoid fever, which is chronic salmonella carrier. So we want to know first what's meant by chronic salmonella carrier. It means that stool cultures are positive 12 months or 1 year after resolution of symptoms. So patients are asymptomatic, but they still carry the bacteria in their intestine, and the incidence rate is 2 to 5% of patients become chronic carrier. And this point is important, by the way. Salmonella typhi colonizes the gallbladder, and this is why chronic salmonella carrier increases the risk of gallbladder cancer. And the treatment is quinolone, such as ciprofloxacin, for at least 1 month if susceptible, plus cholecystectomy. So typhoid fever can cause cancer? Yes. Which cancer? It's gallbladder cancer. So let's come to the next slide, which is about prevention of typhoid fever. As you remember, typhoid fever is transmitted through fecal oral route. And by knowing that, if we ensure that hygiene is maintained and sanitation is maintained, we can limit the spread of typhoid fever. So first point is food and water. We should know that vaccination is not 100% effective or protective against typhoid fever. You remember in our exam scenario, the patient was vaccinated against typhoid fever but still developed typhoid fever, and this is because vaccination is not 100% effective, and measures must therefore be implemented to avoid exposure. So food and water hygiene or sanitation is important as vaccination. And regarding vaccination, it's indicated in people who are traveling to high risk areas, especially East and Southeast Asia, South and Central America or Africa. And there are two types of vaccines against typhoid fever. The first is inactivated vaccine or killed vaccine, and this vaccine contains VI polysaccharide, which is part of the Salmonella typhi capsule, and because it's killed vaccine or inactivated vaccine, it's given intramuscularly. And the other vaccine is live attenuated vaccine, which can be given orally, and this vaccine contains live attenuated Salmonella typhi. And I have a question here. Do you know any other disease which can be prevented by either inactivated vaccine or live attenuated vaccine? If you know the answer, you can comment in this video. So thank you so much for attending this lecture about typhoid fever, and in the post lecture I'm going to send you the PowerPoint presentation, and also I'm going to send you a table about Salmonella infection, Salmonella typhi against Salmonella non-typhi or non-typhi Salmonella. And we have here a positive vibe, which is about the importance of smaller steps. You can see smaller steps are very important than taking extra large steps at the same time. And this is related to typhoid fever, because typhoid fever is associated with stepladder or stepwise fever. Thank you guys, have a great day, bye bye.